Continuing on in our chapter on treatment of psychological disorders, we're moving on to the discussion of biological treatment strategies. So far, we've looked at a whole bunch of different types of psychotherapies, and we've broken them down based on a bunch of our different psychological perspectives that have been relevant throughout the semester. So a lot of those are practical applications of some related concepts from many other chapters. Now we're going to keep on into our biological section, which again is still going to refer back to a bunch of other areas, talking about biological influences, but we're mainly going to be focusing on some very specific techniques, starting with psychoactive drugs, and then moving into some of our different brain manipulation techniques that are a little bit more direct. Let's look at how we treat the brain more directly to differ from how we've been talking about a whole bunch of different talk therapies. So first off, we're going to start with our psychoactive drugs. And every time I teach about psychoactive drugs, I mention the fact that this title, this term, seems to be a lot more impressive than it really is. Sounds very strange to talk about these psychoactive substances, but if something is psychoactive, it just means that it has an impact on some aspect of our brain chemistry. So talking about psychoactive drugs, we're just saying that these are chemicals that are going to be similar to what we already find in our brain. Specifically, they end up effectively imitating or influencing the actions of our existing neurotransmitters. We can specify that these drugs might be synthetic, they might be naturally generated, but they're still going to be exogenous, meaning that they are produced outside of our bodies. Anything endogenous is coming from inside our bodies. But regardless of the source, natural or artificial, these molecules, these chemicals, are going to alter our brain activity because they are specifically changing the chemical processes within our brains, which we should know by now means that they're influencing the patterns of activation. We're changing the action potentials within our neurons, so we're changing how information is moving within those structures. We do also want to note that drugs don't just act in isolation. As always with psychology topics, things can be influenced by other psychological, environmental, and even cultural factors. So we can talk about things like the fact that somebody's expectations can influence the effectiveness of a drug. So the placebo effect is something that very strongly influences how well someone responds to a drug. Basically saying that if you think something is going to work, then you tend to see improvement. Environmental things can be stuff like prior experiences. It could be expectations based on what we've seen others react to certain substances, and so on and so forth. So that component, or I guess that point here on the slide, is just referring to the fact that this is always going to be a little bit more complicated than drug X works in this specific way and has this specific effect. There's a lot of variation there. And then it also gets into the fact that different people will have different natural distributions of neurotransmitters to begin with, which can influence the effectiveness of drugs as well. So again, there's a whole bunch of other factors here, and we are just doing a crash course of the very basics. Another sort of term that you will see popping up is psychopharmacology, which is simply their long name for our studying of how drugs affect cognition and emotion and behavior. Basically, what are the psychological effects and sort of external expressive effects of these substances? How do they influence psychological factors? And when we're talking about our psychoactive drugs, sometimes in, say, the consciousness chapter, if you took 104, we'll talk about all sorts of different drugs, both illegal and legal, but all of them are going to work in very similar ways. Our specific focus is going to be drugs that help with the treatment of psychological disorders, obviously from the chapter, but just acknowledging that there are other categories that are going to be kind of similar in some cases. And then, of course, if we're talking about drugs that are influencing our sort of activity within the brain to try and help treat these disorders, I suppose we should acknowledge the fact that treating different psychological disorders through pharmacological means is actually one of the most common approaches to treating psychological disorders. If we look at some quick facts and figures, there's about 200 million prescriptions written each year for treatment or drugs related to the treatment of psychological disorders. There we go. So the vast majority of these are going to be for anti-anxiety, anti-depression, and antipsychotic medications. So those are the ones that we focus on the most because they are the most common, but we'll throw in a couple of others as well as we move through. So very quickly at the beginning here, if we've said that these drugs are going to be influencing our brains by either imitating or affecting the activity of our neurotransmitters, our naturally produced chemicals that influence activity in the brain, there are just a couple of terms that can be important to know. You've probably encountered this in other places when we talk about agonists and antagonists in terms of drugs. And again, as fancy as it sounds, agonists are things that are going to increase the activity of our neurotransmitters, and antagonists are going to decrease or inhibit activity of a neurotransmitter. So the reason why I wanted to talk about these terms is actually to talk about the logic behind why they might increase or decrease the effective activity of a neurotransmitter, because some of our drugs are going to be acting as agonists or antagonists and changing brain activity accordingly. So our base logic here is looking at the release of neurotransmitters or the action of neurotransmitters. And I guess I'll actually include this diagram here as well. As always, the diagram itself is not the important part. I just find it's very helpful to illustrate the processes. But as a quick refresher, we have here one of the parts of a neuron. So this neuron, this cell is sending our electrical signal. We have an action potential and it's heading down the cell and it has to send the signal across to the next neuron in the line. So they'll usually talk about this as the presynaptic neuron because this gap here is called the synapse. And this is our postsynaptic neuron. None of that really matters beyond helping us orient ourselves. The goal here is talking about the fact that in order for our electrical signal to go from one cell to the next, we actually use our neurotransmitters, those tiny little chemicals that are going to be released from the earlier cell and are going to act on the later cell. So in order to have these neurotransmitters play a role, they have to be produced. So if we influence how much neurotransmitter is produced, we can make more or less of it. So if a drug comes in and tells a cell to make more of a neurotransmitter, then we have more that can act on the cell that's next. So by increasing production of a neurotransmitter, we see that that drug would be an agonist because we've made more of it, more is now released. That neurotransmitter is now more active than it was before. If we do the opposite, if we maybe reduce the production of a neurotransmitter, we would then have an antagonist because we are reducing how much is available. We are reducing the activity of that neurotransmitter. So I like having the visual here to see that these are being released, but the production, the amount that we're making, is what determines how much ends up within that space between our cells. And again, if we scroll back here, we're talking about producing. We'll also look at how much we store and release of these for antagonists and agonists. So this is me talking about these points, but while looking at something that's relevant. So first off was the production. How much is the cell making? Storage is just talking about how many of these little storage vesicles do we have. So you can think of these as like our warehouses. The more warehouses we have, the more of that neurotransmitter we can store to use. More means that it's going to act more effectively, so we're increasing functionality. And even the release part, if we make the cell more likely to empty these warehouses into that gap between our cells, then again, more neurotransmitters present, more activity. And if we do the opposites, if we are less efficient in storage, if we are slower to release it, we decrease the activity. So that's the first part, is just making and releasing our neurotransmitter. The next thing that can be changed is actually how it interacts with the cell on the other side. So these receptors are kind of like the locks to that next cell. So if we think of the neurotransmitters as a key And this as a lock, the neurotransmitter has to fit into that lock to be able to activate or affect this cell. So if a drug comes in and blocks that specific receptor, we are preventing the neurotransmitter from acting. Some drugs are actually going to come in, they're going to fit to the receptors, but they're actually going to activate the receptors. So they could increase the activity by basically pretending to be that neurotransmitter. So we can have an increase or decrease by interacting right with these receptors. So if it maybe fits into the gap, but it doesn't activate the cell, then it's just taken away a place that the actual neurotransmitter could act. So we're preventing it from being very effective. But if our drug binds and then produces a signal, then we're going to see that that's going to imitate the neurotransmitter and increase the effective activity. And the last thing, and the one that's most important when we start talking about our antidepressants, so very much the one I want you to take home from this, is actually the fact that once we've dumped our neurotransmitters into the gap and they've gone and done whatever they're going to do, the cells typically clean up the mess. So we have a process where we will reuptake, go in and collect all the neurotransmitters and put them back into these storage vesicles. So if we increase the rate of reuptake, we're basically cleaning up faster. And if we get rid of our molecules very quickly, they have less time to act. So by having faster reuptake, we have less action for those neurotransmitters. If instead we say slow down or inhibit reuptake, we're then allowing those signals, those neurotransmitters, to stay in that gap for longer, which means they're going to act for longer. So in this case, it means that they're having stronger signals because the neurotransmitters stay in that area for much longer than they should have. So a drug that comes in and prevents reuptake is actually going to make our cells think like there's way more neurotransmitter than there is. So we're increasing that activity. And again, all of these descriptions are me talking about these specific points here, just while looking at the visual so I can gesture to it. So if you like the words are here, but the image also does that as well. And if you wanted to read through the specific descriptors here, they talk about agonists and antagonists and how they act. So if you want the visual and the words without sort of just me talking over them, that figure does that as well. So again, that reuptake is probably the one that comes up most often when looking at our different drug types, but I figured I'd explain all of them because understanding the process of making and then storing and then releasing and then cleaning up those neurotransmitters, that's really important to understand the logic of this process. So with that possibly refresher, possibly crash course on neurotransmitters, I want to start getting into our specific categories of drugs. The first of these are our antidepressants. And we're going to talk about three major categories, two of which are ones that are kind of the non-preferred options. These are typically used a lot less often. I believe they're both older types of antidepressants than what's more commonly used nowadays. So they tend to have some very specific side effects that are not as great as the others. So these are usually only used if the more common types of antidepressants are not super effective. So these are non-preferred types. The first is our tricyclics, and these are going to increase the activity of norepinephrine and serotonin. So norepinephrine and serotonin are two types of neurotransmitters. They are specifically excitatory neurotransmitters, not that that's the important part, but what we care about here is the fact that tricyclics are going to prevent the reuptake of these two neurotransmitters. So by preventing that cleanup stage from over here, we're leaving those two neurotransmitters in that synapse for longer, which means they're going to have longer to be active. So we're ending up with more activity for norepinephrine and serotonin because we don't get to clean it up as quickly as the cells would on their own. Then we have our monoamine oxidase inhibitors, MAOIs, and these are going to also increase the activity of norepinephrine and serotonin, which if we think about the biology behind depression, that kind of makes sense. But we know that monoamine oxidase, that's a very specific protein that's going to go in and break down neurotransmitters. So sometimes cells, instead of reuptaking or cleaning up and recycling the neurotransmitters, what they'll do is instead send out things like these monoamine oxidases, and they'll break down those chemicals, the neurotransmitters, into their individual components. Basically, they're going to tear them apart, turn them into amino acids, and use them for something else. So our MAOIs are going to prevent this specific protein from cleaning up those neurotransmitters. So we're preventing this breakdown, meaning that those neurotransmitters stay active in the synapse. So we get the exact same logic between these two, except this one is interfering with cleaning up through that recycling process, through reuptake, whereas this one is keeping them active by preventing a breakdown where we're going to sort of pull them into constituent elements and turn them into something else. But in both cases, we're basically letting those neurotransmitters stay active and stay in the synapse for longer, and therefore increasing the activity of these two neurotransmitters. All right, and if those are the uncommon types, what are the common types? We're typically going to see SSRIs as the standard. So these are selective serotonin reuptake inhibitors. So once again, serotonin is very important here, makes sense for depression, but from the name, we can probably figure out what these do. So they are going to inhibit serotonin reuptake. So they make serotonin more active by allowing it to stay in that synapse for longer. If we block reuptake, we block that collection and recycling and reusing of the serotonin neurotransmitter, so it stays in the synapse longer and it's going to act for longer. These tend to be much more mild in terms of side effects than the others, usually because of this selective component. It doesn't block all serotonin reuptake. It's going to be more selective in the process. Basically, it acts more strongly in certain areas than others. Our understanding of how it works is not fantastic. We know the basics, but a lot of our psychoactive drug treatments are kind of guesswork at this point, but that's as much as we know. It tends to also be a lot more rapid in terms of taking effect, but it is kind of important to note that a lot of these drugs, because we're trying to change the activity within the brain, sometimes it can take weeks into months for them to take full effect. So typically, if someone is told to start taking a new drug, you have to sort of gradually get larger and larger doses until you hit the normal prescribed amount. And then you usually have to wait up to 6 weeks before they'd expect to see any kind of solid change in your mood. So it's good to know that these are very slow acting, even the ones that are supposedly more quickly acting. So it can still be multiple weeks before you'd see a change. I also figured I'd mention here that instead of just serotonin reuptake being inhibited, we can have serotonin and norepinephrine reuptake inhibitors are their own category, or norepinephrine and dopamine reuptake inhibitors. Those are a little bit more recent, but not as common as SSRIs. So I'm just letting you know they exist, but we're not going to talk about them. I'm sure you can figure out from the names how they operate. And this is just another one of our diagrams that's showing specifically our MAOIs and labeled, SSRIs labeled, and the tricyclics labeled, once again, if you like those visuals. Next category of drugs, though, is our antipsychotics. So these are used to treat schizophrenia and related disorders. So these are very interesting because when we've talked before about the fact that we have that deinstitutionalization cycle, we actually can credit a lot of that initial switch to trying to get people out of institutions to the creation of antipsychotics. Specifically, our first generation antipsychotics like chlorpromazine, there we go. This is one of the first that was developed And it was really, really effective in treating a bunch of symptoms of schizophrenia. Now, if you remember our discussion on schizophrenia, though, you remember that there are two broad categories of symptoms. And with our new updates to the DSM-5, we actually had to change a bunch of our categories for schizophrenia. And we specifically talked about positive versus negative symptoms, or type 1 versus type 2 schizophrenia. If we were looking at the creation of these first generation antipsychotics, these were developed in about the 60s. So at the time, they just talked about all types of schizophrenia as the same thing. So they found that these drugs were very effective at treating some individuals, but they had almost no effect on others. Nowadays, we know that that's because these drugs end up acting in a way that's very effective at treating our positive symptoms. Specifically, they tend to decrease the overactivity of dopamine, but newer drugs will affect both dopamine and serotonin, depending. Introducing that serotonin component as well actually ends up making them a little bit more effective for our negative symptoms of schizophrenia. But that is a very, very recent evolution. So, first off, with our first generation antipsychotics, while they were very effective at controlling those positive symptoms, there was also a pretty large downside to them. So, this is something called tardive dyskinesia. And this is a degenerative symptom where, when you have very high levels of those first generation antipsychotics in your system, they actually end up blocking dopamine activity pretty much everywhere in the brain and at very high levels. And doing so for long periods of time will actually end up influencing our motor abilities. So, a lot of our, say, intentional actions, intentional reaching type behaviors are going to be influenced by dopamine within our motor pathways. And so, messing with the expression of dopamine throughout the brain ends up leading to things like tremors and uncontrollable movement. And if it goes on for long enough, it ends up being irreversible. So we cause permanent damage to those pathways that use dopamine. It actually ends up looking a lot like Parkinson's disease with uncontrollable movement tied to dopamine. So it was one of those very bad side effects. But when the alternative was having very strong positive schizophrenia symptoms, people usually still went with the drugs. Um, Fortunately, after some time, we actually ended up with our second generation antipsychotics. So this includes, usually people talk about Haldol or haloperidol. That's one of those second generation antipsychotics. And for once, having a new drug that ends up sort of trying to get rid of some symptoms, it's not only getting rid of those symptoms, so it doesn't have the side effects of tardive dyskinesia, but it's actually even more effective at blocking those positive symptoms. So we ended up with the best of both worlds because now we're more effective at treatment and there aren't as terrible side effects. And then continuing on from that, we have other antipsychotics that are continually being developed that are then targeting not just dopamine, but serotonin as well. Those are usually called atypical antipsychotics just because they're targeting multiple symptoms, but our systems, sorry. But like I said, that's actually because we're trying to also treat negative symptoms of schizophrenia. And again, from the previous chapter, we know that there's a pretty big difference in where the two different types of schizophrenia come from and how they act and sort of their responsiveness to different drugs. And this is why. We're talking specifically about dopamine for most of these, though newer advances are starting to look at serotonin as well. And then this diagram here, it's not super important, but I just wanted to show the very dramatic decrease in hospitalization, or I guess institutionalization, that came with the development of our antipsychotics. So specifically, if I said sort of mid to late or mid 50s to early 60s is when these became really popular, and we see this massive drop off in the number of people institutionalized. This was one of those driving forces that allowed people with positive symptoms of schizophrenia to actually go back and integrate into society and live relatively normal lives because their symptoms were under control. Next, we get into our anti-anxiety drugs. So the ones that people might know are going to fall under our benzodiazepines. And so this would be things like maybe Ambien, or what was some of the other ones? I don't really remember those, and I don't think I made notes of them. But we don't care about the specific drugs. What we do care about is the fact that these anti-anxiety drugs typically work by modifying GABA, which is another one of our neurotransmitters. So it is gamma aminobutyric acid. GABA is sufficient. So in these cases, these anti-anxiety drugs are supposed to help calm our autonomic nervous system, and it tends to be very effective. It also can be prescribed for things like insomnia. So if you're having troubles relaxing enough to sleep, these can be prescribed for that as well. So these are typically called sedatives because they sedate or reduce activity in our autonomic nervous system. Of course, there are some massive concerns here. With those sedatives, we have some pretty big issues with interactions with other drugs because we are suppressing a lot of our autonomic responses. If you take too much or take this drug in combination with something else that suppresses that system, you can have issues with, say, remaining conscious. If your breathing slows too much, it can end up being fatal. And this is compounded by the fact that if people take some of these drugs for long periods of time, they are very susceptible to building up tolerance, which means that you have to take larger and larger doses of the drug to get the same effect. Effectively, our bodies learn to anticipate the presence of a chemical in the body, and it starts to compensate for that. So you need a larger dose to overcome our bodies trying to level things out. And one special concern here is something called selective tolerance, which means not only do we have the fact that our bodies build up a resistance and we have to take larger and larger doses, but the fact that these specific drugs can affect multiple systems, they can actually end up developing tolerance to only some parts of the drug's action, which means that if you're taking larger and larger doses to try and reduce your experiences of anxiety, you can actually find that you end up with larger and larger effects on other systems because the body hasn't learned to compensate in those systems. So selective tolerance means that you might end up with overdose situations for only some of the effects of the drug. And again, because we're just doing this very briefly, these are more of there's lots of concerns here, and this is a very special category that have a lot of issues with, say, overprescription, and it's a very interesting area to look into. But we get exactly one slide. The next slide is another quick one looking at mood stabilizers. Basically, we're talking about lithium. And this is one that's very much described for our bipolar disorders. And as the name implies, mood stabilizers help stabilize those shifts in mood that are very typical of bipolar. So in this case, we are trying to level out those swings between mania or hypomania, depending on the type of bipolar disorder, all the way into depression. And one of the important things to note here is that while we do call major depressive disorder unipolar depression, and we say that the depressive side of bipolar disorder is very, very similar in expression, you can't use antidepressants to treat to treat bipolar disorder in most cases. And the reason for this is because with our mania and depression and the swings between, the issue is thought to be that dysregulation where the processes are sort of overactive and then underactive. So taking an antidepressant would bias that system in one direction. Effectively, it would make the mania worse by trying to treat the depression. We can go the other way, where sometimes you can use mood stabilizers to help with depression, but you can't use antidepressants to help with bipolar. And then towards the end here, just talking about the combination of drugs and psychotherapy, because the two are often used hand in hand. Is it effective? Which is better? Oftentimes using them in conjunction can be very effective. And while some people will have a preference where they think that talk therapies are more effective versus drugs being more effective, what we find is both tend to be very effective. And in fact, either of them, either are therapies alone or drugs alone, or drugs and therapy in combination, we tend to see them being pretty much equally effective depending on the situation. But the important part being that they are more effective than not receiving treatment at all. So they do tend to work, and this can be a matter of personal preference as to whether you use one, the other, or both. One of the things to consider, though, is the fact that it's going to depend on the person receiving treatment, where you are seeking treatment, and what you are seeking treatment for, because the particular disorder that you're working with, the symptoms for that specific disorder, where you are and who you are, all of those can affect what you do and how it works. So we also kind of acknowledge the fact that in order to both get your talk therapy and a drug prescription, you sometimes need to have both a psychologist and a psychiatrist working together to try and integrate those treatments. And sometimes you'll have them working in opposition, where maybe you get the drug from your psychiatrist and then you go to talk therapy with the psychologist, but there's no integration. And that can be problematic or not, again, depending on the situation. But this diagram here is just meant to show that, so here is cognitive behavior therapy alone, so psychotherapy on its own. This one is going to be a drug on its own. Here's our placebo, basically saying that people think they're receiving treatment, but they are not. And then here we have both the drug and the therapy together. We see that the combination looks to be more effective than either on their own, but either on their own is still more effective than the placebo. Again, stressing that this is from one specific study with one specific type of therapy and one specific type of drug. So take that with a grain of salt, but it at least shows the pattern that we're talking about. This other graph here, again, where the graph itself is not important, but the message is important. Here we're looking at different parts of the brain that are going to be showing changes in neural activity. These are relevant areas to, I think this was looking at depression. Oh yes, SSRIs, so antidepressants. So here, the amygdala, the hippocampus, our temporal cortex, these are showing about equivalent changes with psychotherapy in the red and the SSRIs, drug therapy, in the purple. They're all very, very close together. And if we're seeing reduction in neural activity, this is sort of a weird one. The reduction in neural activity, and they're negatives, meaning we're increasing activity because depression tends to suppress activity. However, so this is just saying that these are good, and the fact that they're close tells us that the talk therapy and the drugs are both effective. They cause a change. It doesn't include a placebo to compare against, but whatever, it gives us a pattern to observe, and that's all that matters. Now we get into some non-drug related biological therapies. And starting off with an interesting one, which is electroconvulsive therapy, or ECT. Now, when you see ECT, people tend to get really upset that this is something that's mentioned as a modern treatment. And that's mainly because our typical understanding of ECT comes from, say, horror movies, or TV renditions of mental institutions from the 1960s, when electroconvulsive therapy was used in a pretty aggressive and not super ethical way. But of course, in modern practices with modern ethics, we have very strong rules and regulations around when and how you can use ECT. So historically, electroconvulsive therapy, which is applying an electrical current to the brain to try and affect the activity, because brain activity is itself electrical. This actually came from the fact that they noticed that people who are diagnosed with schizophrenia are almost never going to experience epilepsy. And if epilepsy is uncontrolled electrical activity in different parts of the brain, they said, well, maybe this uncontrolled electrical activity is actually then treating any type of psychotic disorder like schizophrenia. So they figured they'd try it. Let's apply electricity to the brain and see if it helps reduce symptoms of things like schizophrenia. And interestingly enough, it was effective. Of course, lots of concerns about the fact that you are applying an electric current to someone's brain, but in some cases it can be really effective. In modern uses, it's used in very controlled environments. It has very specific, very low voltages. There are specific ranges. They actually have limited numbers of treatments that can be performed on an individual, and you are not permitted to exceed it for fear that it can cause long-term damage. In between sessions, you have to go and get brain scans to prove that there has been no long-term changes in your brain structure. So they want to make sure that it isn't having a bad effect before they proceed. But in some cases where, say, you have treatment-resistant depression or treatment-resistant mania, it can be a viable option. Obviously, most people are not going to choose this as their first option, but if you have a case that's severe enough and hasn't been responding to other types of therapy or other types of treatments, this can be an option. Of course, lots of criticisms for it. Outside of the ethical concerns, there are the possibilities of memory loss, damage to different brain structures, and it tends not to have very long-term effects, but it can be effective, especially very quickly. So it can have very quick effects on especially depression. Similar in concept, but not so much in dangerous side effects and execution, is transcranial magnetic stimulation, or TMS. So TMS is going to be applying a magnetic current to the brain to influence electrical activity. So here, instead of using electricity to trigger electrical activity, we're just using magnetic fields. So these magnets, the magnetic fields produced by them, are going to create pulses of activity in very specific parts of the brain. And by targeting very specific pathways, say things like our reward pathway, those can end up causing an increase in activation after the treatment sessions. Effectively, you're going to make a pathway fire consistently with the magnet so that in the future it's more likely to fire on its own. When certain parts of the brain are used consistently, they become more active. It becomes easier to use it the more it's been used in the past. Basically, our brains learn to try and predict the needs for activity. And if we're targeting, say, those areas related to motivation or I just said the word, enjoyment, pleasure, there we go. It can help with things like depression, which would have underactivity in those areas, tying to things like apathy and not being motivated. So this is kind of a newer type of technique. It's only recently become very popular, but it seems to be a significant improvement on ECT. Another not commonly used is psychosurgery. And this is something we've seen in our case studies, looking at individuals like HM, who had large parts of his brain removed, specifically his hippocampus, to help with a really severe case of epilepsy. We, of course, use him as an example of, we now know that the hippocampus is tied to memory, so that caused problems with his memory, but it did also technically effectively stop his epileptic seizures. So in that case, kind of worked. Nowadays, again, psychosurgery is really, really rare, and it's only used in very severe cases, and again, only if all other options have been exhausted. It's typically used for things like, say, OCD or severe treatment-resistant depression. So say a cingulotomy, which is when you're cutting the fibers, at least a couple of fibers in the corpus callosum, and removing some of the nearby or damaging some of the nearby cingulate gyrus. That has been fairly effective. But psychosurgery just refers to any kind of damage, destruction, or removal of certain parts of the brain to stop them from functioning. So very much tied to treatment-resistant things. Also, epilepsy is commonly mentioned just because you try and remove the areas that are creating that uncontrolled electrical activity that's affecting other parts of the brain. But there's lots and lots of different types of psychosurgeries. We're just stressing the fact that they are rarely used and only for very specific cases.